So a lot of times people may ask questions about how do I know if my loved one would be a good fit for palliative care? Or can you give me an example of how a patient of yours, use palliative care as a means to find their way to being into hospice care? And I do have quite a few examples of that. Have the program in place for almost 2 years now, and so we've seen a lot of families kind of transition through the spectrum of palliative care into hospice care. One example I can think of in particular that really stands out to me is we had a woman who was living with her family. She had a diagnosis of Alzheimer's disease. And the family had kind of gotten to a point where, her disease had progressed. They were working so hard, so diligently to care for her in their home. But things were getting different where there was more safety concerns. She was having some more falls. She was sometimes wandering, and they were worried about her safety in their home, so that she needed someplace more secure. So the conversation started to shift towards maybe finding a place that had 24-hour caregiving, so to kind of place her in a memory care unit, help get her transition to that being her living environment versus living in their home and having them be their caregivers, her caregivers. Along with some of these safety things, the falls and some of the confusion where she would wander, and they concerned for her safety, she also was experiencing some scarier symptoms for her personally, which were, she started, talking about people and hallucinating a little bit. She also, with that, was developing a little bit of paranoia where she would be pretty agitated. And we obviously know that when someone's in that kind of a state in their disease process, it's not comfortable. It's not comfortable to be scared or paranoid. It's not comfortable to be agitated and restless. So in line with our palliative care principles of providing comfort through symptom management, we started talking about what medication options they'd already tried with their neurology team, and also, maybe ones that hadn't been tried yet. And so we were able to move into a space of trying to manage some of her symptoms with some different medications. And the one thing that was really nice, which was different for palliative care alone, or I should say neurology alone, right? They'd been working with a neurologist, but it's not like the neurologist is at the home. The neurologist isn't usually seeing the patient in their living environment. So we were able to bring, with palliative care in conjunction with neurology, a kind of a view or a lens that was more unique and more specific to this patient, where we could see her living environment. We could see some of the challenges that her caregivers, both at home and now in her memory care unit, were experiencing for her. And we were seeing her more frequently. So we made the med changes. We could see the change, if those changes were working or not. We had just a little bit further forward ability to have a view of the patient in their care setting. And so we tried a couple different medications over a couple different months, and the disease was progressing. At a certain point, no matter what we do with interventions, the diseases do progress. That's unfortunately the reality of health. And we were able to keep up with those disease changes and make adjustments to the medication. Eventually, she did get to the point that despite no matter what med changes we were making, they weren't really holding her symptoms anymore, and that's when we knew it was time to really have the conversation about hospice care. That is oftentimes something I really encourage patients and families to talk to their other specialists about, is when they start to find themselves in a pattern of, okay, we tried this med, it worked for like a week or two or maybe a month or two, and now it's not working. We call that treatment resistance. And so when we see that happening, and in spite of all the interventions and all the medications that we've tried, they either manage for a short time or they don't really get the desired effect, we know then it's time to really start talking, and our red flags or little spidey senses maybe should start tingling a little bit on, is it time to start really thinking about how could hospice care better serve this family earlier, right, versus in an emergency. And so that's kind of how this case went. We talked with the family and said, hey, we've tried different things. We do feel like we're now at a place where we make changes, they work for a week or so, and then there's some resistance to that treatment, which tells me that the disease is moving faster. and it's time for us to really talk about whether or not hospice is a part of your goals for your mom. And we were able to transition her to hospice care. She lived for a couple more months on hospice care, so that was wonderful to see them have such robust care around their family for a couple months. And eventually she did pass away on hospice, and she was very comfortable and symptoms were managed, and it felt like a very good collaborative effort between the family, the patient, her neurologist or other specialists, palliative care, hospice, like the whole spectrum. It was really, I get goosebumps actually, really beautiful to be a part of.